Just for the recording, good morning and welcome to the latest in the series of GameShift pop-up events. It is our last one before what was euphemistically called the British summer, because we won't have one in August, and then we will come back in September, and hopefully it will be beautifully sunny by then, and we will get a long longed for Indian summer. So good morning and really warm welcome to Gemma Lloyd, who is coming to talk to us this morning about her experience as a palliative care nurse and linking it, we're going to link it to organisational life. But Chris, do you want to just introduce a little bit more? Chris, my co-founder of GameShift.
Hello, everybody. Good to be here. Well, lots of familiar faces, so good to see you all, and some new folks, so welcome, everybody. I'm just delighted that we're doing this. So I'm not going to say too much at all, but it would be brilliant to, if some people are willing to speak, just to let Gemma know what it is that draws you here today. So either putting it in the chat or preferably just speaking up, and we just have a couple of minutes for people to say what it is that causes you to be here.
Don't wait to be asked, just go for it. Sarah,
go for it.
Oh,
yeah.
Hi, everybody. I'm Sarah. I'm new. I've not been to any of these sessions before, but I was very drawn to it because I've been thinking a lot about endings of projects, endings of or shifts in culture, and I'm very interested in OD from a Gestalt perspective. So the whole idea of endings feels really important to me. So that's what brought me here today.
Thank you very much. Yeah.
Hi there, I'm also new. My name's Caroline Beardle, and I'm known as the head gardener. Now, gardens grow or fade, and so do people. So my coaching practice is all around behavioural science and neuroscience of actually how all that works. But one of the areas I'm particularly working on at the moment is around transition and the ending. And I have a little nugget of an idea of another book that I'm thinking of writing, which will, the working title is Euthanasia and Sprouts. So I'm hoping this is going to give me some ideas, and I'm hoping that I can learn and reflect from what it is that Gemma shares with us.
Wonderful. That's brilliant. Love your title, by the way. That's very good. Yeah.
Just to chip in, so I'm really looking forward to the talk. Always these sessions are thought-provoking, and but particularly this one. So I work a lot with healthcare organisations and systems, and what with the NHS being broken and all is, but you know, kind of both cultural and operational shifts that are needed. Is kind of reflecting on those transitions and what do we need to be ready to let go of. So really interested to come out of what hear what comes out of the session.
Lovely, thank you, Ed, and good to see you here. And
thank you also for the plug. Thank you also for the plug. We'll get you to do all our advertising for these pop-ups.
Yeah. Well, he said it's on the recording, so we're going to have that cropped, Ed, and put up on billboards and everything. So thank you. Yeah. Polly Plunkett. Polly, you in the chat has said, hello, Polly. Do you want to say it or shall I just read it?
Sorry, yeah, I'm happy to say it if you'd rather. I'm new to this session, and I was just saw it on I think it was social channels, and I'm at a point after 40 years in my career where I can't retire, but I no longer get fulfilled at all in my professional pathway, and it's time for a change. And what I don't want to do is do what I've done before, which is let events shape my future, either from other people's agendas or because of circumstances. This time I'd like to lead it myself, and I don't quite know where it's going to lead me to. So I'd like to learn how to do a good ending.
Fantastic.
I'll say something.
Any more? Yes.
Yeah, I can't find the hand raise. So I do these.
Oh, don't worry, just speak. It's fine. Yeah.
I'm Jo. This is my first session that I've been able to attend, but I've been interested for a little while. And my first career was actually in speech pathology. So I'm interested in yeah, I guess the endings in our real lives are really significant, and I'm always interested in perspectives that integrate from different disciplines or different kind of places in which we gain understanding and experience. So that knitting together really drew me. But I'm also working in change and from a Gestalt and systemic coaching perspective. And so understanding the ways in which, you know, endings enrich our beginnings is also really interesting from that perspective too. So I kind of hold both today.
Fantastic, thank you.
I
I thought there was at
Emma?
least one more. Yes, keep going.
Sorry. Yeah, so Emma, sorry, I've actually got my wrong name on the screen. It's Emma Hayes, but yeah, I saw this on LinkedIn and really drew me because I ended my employment with the NHS after 22 years this year. It was something I kind of had in mind and I knew I wanted to do. And unfortunately, yeah, in terms of the way that endings occur, I think for me, had, you know, really open and transparent conversations, and it still didn't end the way I wanted. But actually the most important thing was I did manage to leave. And for me, I think, yeah, that importance and impact that on our well-being that endings have in terms of kind of perspectives, preparation, and then taking that forward in terms of coaching, facilitation, and still working in NHS and care is yeah, I really value the insights, so thank you.
Wonderful.
I'll
And
say
Jane,
something.
yes, sure.
I've been interested in this for a long time. I've actually got a piece of dried up masking tape which has fallen off my monitor now, which says, "Am I a palliative hospicer?" I've been working on climate adaptation since the early 2000s and been thinking about how I'm trying to help corporations give up on assets, particularly if they're in the wrong places or agricultural land. But more and more, as I've been coaching and working on leadership development, and now I work alongside Chris and Philippa and Rick and Alex in GameShift on occasion, but also have a community interest company which looks at leadership in the context of the climate and ecological emergency. And that's really brought it to the fore, because how do we relinquish things that we're so attached to? How do we let go of things? And I'm really interested in what we might talk about today in terms of relinquishing ideas about identity, obviously stuff. What about ideas of successful lives? And these things all seem so central to when I'm working with leaders when it comes to climate adaptation, because we often talk about relinquishment as being something that we have to give up and that's really painful. And of course, there are aspects of that. But relinquishment is also something which gives us freedom. So I'm really interested in the intersection of the pain and the freedom that comes. And I'm looking forward to hearing Gemma talk to that. And curious about how that fits with the work I'm doing. So Chris and Philippa, thanks for setting this up. And Gemma, thanks for coming along.
Brilliant. So I think that's all the hands and nods I saw. So Gemma, if it's okay with you, we'll make a start. Now, I think by way of intro, I think it's fair to say I haven't asked Gemma to come to be an expert on all of those things. So our intention is that Gemma is an expert on being a palliative care nurse and working in hospices and that kind of thing. And but she is also training as an organisation coach, so she knows a fair bit about coaching these days. But that we all work together to apply what we're hearing and also to make sense of it together. So that's the invitation. Yeah.
And as we go along, I mean, Gemma, you might invite questions at different points, or if you've got something you want to put in the chat, I'll keep an eye on what's going on in the chat. But equally, we really want this to be a conversation. So if you do have something you'd like to say, please either just put your hand up or just say, "Oh, I've got a question," because this is very very informal.
So by way of intro, I mean, it's fair to say I've known Gemma quite a long time.
A little while.
A little while. In fact, since 2 days before Live Aid, which is when Gemma was born.
Yeah.
So if you remember the Live Aid concert, 1985, Gemma, you were born on the 11th, and I think Live Aid was the 13th.
Okay, yeah,
I'm Gemma's dad, but Gemma has cunningly changed her name here so that you can't tell the family connection, which I think is a really good ruse. Well done, Gemma.
thank you.
Because otherwise we'd have three of us in a row on my screen. Yeah.
Yeah.
So, Gem, I mean, do you want to say something about why you're here doing this today and why you agreed to do it?
I'm here because you asked me. I've been obviously been a palliative care nurse since I qualified as a nurse back in 2011. So illness and death is something that is just, I support people with on a daily basis. And then more and more, conversations I've had with people, particularly since I started my coaching training, I've just noticed this sort of crossover between the endings in palliative care and and how important it is to recognise endings, and how little they're often paid attention to in businesses and organisations. Thought it'd be an interesting topic to discuss.
Yeah, and thank you. Now, I don't know actually where to start because there's two different ways we could start. One is about how on earth you got into all this, and the other is what is all this anyway?
Yeah.
Yeah, because I would like you to say something about what palliative care is and what a hospice is and where the hell the idea comes from. But also I want to say something about you and how you got into it. So which would you like to start with?
I mean, should we just we could go with how I got into palliative care is probably a good place to start.
Okay.
So I'll go there. I mean, when I was, an 18-year-old, bright-eyed out of school, I was determined I was going to do art and fashion design, and that quite quickly slipped to one side when I realised, definitely not for me. And then I had a few years working in finance and banking, and was actually planning to become an accountant. But I decided I wanted to do some travelling before I qualified. So I up sticks with a friend and went to Africa for 4 months, doing some voluntary work and sort of travel through 10 countries. At the end of it, I think wanted to just run off and return back up to Kenya. Unfortunately, all the riots had broken out. It was 2007, so thought you and Mum would probably think that was not a good idea and came home. But I then wanted to train in something that actually meant I could help people and really wanted to go back out to Africa. So decided I was going to become a nurse. And my plan at that point was to actually study sexual health and HIV and go back out there. But during my training, I obviously encountered a lot of end-of-life care in hospital wards, in patients' homes, in care homes and things. Some not so great and some absolutely phenomenal. But I realised that was actually where my calling was. I absolutely loved looking after people at that point in their life. It's you only get one chance at it. And it's a privilege and something I absolutely adore doing. During my final year of training, my granddad got leukemia. I moved in with him and grandma and helped look after him while he was dying. And again, it just cemented, there were conversations that happened not particularly well. And just really, really proved to me it was right. It was what I needed to do, that I could work on. And that's sort of where I then went, and a lot of the time my focus is it's a lot of the focus is obviously on a patient and how and their symptoms and things, but it's also that support for the family and the people that are going to live with that memory and helping them process everything that's going on and their transition through the loss of a loved one.
Yeah. So you were already, my memory is hazy. So you were already well into your time at King's when Grandad got ill.
Yes, yeah,
Okay.
it was my
Hmm.
final year. I think I had about 6 months left of training when he was diagnosed with leukemia.
Yeah.
And he
And had you
died
been
about 3 months later.
and had you been at St. Christopher's then as well?
I hadn't.
Ah,
So it was from the beginning of my final year, it had become a thing that I thought I wanted to do my final placement. So at the university, I went to King's, and your final placement as a nurse was 3 months long. And I'd already been thinking I wanted to do it. But as I say, looking after Grandad, and some of the things again that went well with him, but also some of the things that weren't handled as well as I feel they could have been, just drew me and absolutely cemented that that's what I wanted to do. And then I managed to get my final placement at St. Christopher's, which I think started a few weeks after he died, which
right.
was a bit
And
of a...
you better say what St. Christopher's is, because it's quite famous, isn't it?
It is. So I suppose that's where we can kind of link into the history of what palliative care is, really. So St. Christopher's Hospice is down in Sydenham in South London. And it was the first what's called sort of modern hospice to be developed. It was opened in 1967 by Dame Cicely Saunders, who, when I was preparing for this chat and having a good read, I realised I could probably talk about all day. She's yeah, a very, very influential woman in the 20th century. She was originally, I think, training, I can't remember, in like sociology and things at Oxford University when World War II broke out, and she decided she wanted to do something more meaningful with her life, so she trained as a nurse. Then towards the end of her nurse training, she hurt her back, so couldn't, basically stopped almost instantly afterwards. So then trained as a social worker. While she was working then as a social worker, she particularly focused her time looking after people who were dying. And there was one gentleman she met, I think his name was David Sama, can't pronounce his surname, but when he died, he donated her some money, and sort of left a prophecy, as it were, of let me be a window in your home. And the conversations they'd had up until his death had been all about her setting up somewhere, a home specifically for people who were dying, where they were really cared for medically as well as with compassion. Up until that sort of the point where she started doing this, a patient dying in healthcare was seen as a failure. So once a patient was seen as incurable, they were sort of pushed to one side. They were left to suffer in pain. Their pain regimes were managed the same way anyone else's were, and it was like, well, it's just got to wear off before you can have more. And she realized that was not good enough. And someone should, okay, we can't cure the cancer or cure whatever's going on, but we need to then change that focus and keep them comfortable, and they are still a person. And one of her biggest, I can't remember it exactly, but sort of the thing, her mantras, I suppose, was we care for you because you are you, and we care for you until you die. Because previously it was just brushed to the side. So this is what she was developing as a social worker, and she spoke to consultants and things on the hospitals she was working in, and they all basically said, well, that's great, but no one's going to listen to you as a social worker. You need to be a doctor. So she took up that challenge, trained as a medic, and I think she qualified from St Thomas's Medical School in about 1957, and then, as I say, and worked over the next decade to raise the funds, etc., to set up St Christopher's.
Brilliant. Thank you. Just while you were saying that, it reminded me of something on the BBC about her.
Oh, you've gone mute.
while you were saying that, Gem, it reminded me of something on the BBC, on the Great Live series, where Maureen Lipman talked about Cicely Saunders. So I've put a link, so anybody who wants to can cut and paste it into something and look it up later.
Yeah, thank you.
So I know we could talk about Dame Cicely all day, but
Yeah.
palliative care,
Yes.
what actually is it?
So again, thought good way to do this. We'll start with the World Health Organisation's definition of palliative care. Because it does sum it up quite nicely. But an approach that aims to prevent and relieve health-related suffering of adults, children, and families facing problems associated with life-threatening illness. And I think this is a really key point, and I'll come back to it. But it's based on comprehensive and person-centered approach, addressing physical, psychological, social, and spiritual suffering. So the reason I say it's the problems associated with life-threatening illness is because a common misconception in a way about palliative care is that it is all about dying. It's all about the end of life care. But actually palliative care, just because of its holistic nature, can be used throughout almost anyone's illness. You know, once someone has that life-threatening, they might have cancer that's curative, but they will always have that niggle that it's not, and they start questioning things. And they need this more holistic approach to their care, to the questions that are asked. So actually, I think palliative care did very much start with the dying patients, but over the years, it has actually come to include just anyone that is facing that potential sort of outcome from an illness. Saying that, so often things like the oncology nurses and things will do things, I think it's called a holistic needs assessment with patients, where they cover questions related to all these topics. You then get specialist palliative care, which is where I fit in, and you know, my wider team, where we really focus then on the people that need much more complex symptom management, more complex psychological support and those sort of things. But palliative care in general can be dealt with by, let's say, GPs, community nurses, yeah, everyone basically in healthcare. So yeah, there's a bit of a difference at the moment between palliative care and the technical end of life care.
Okay, right. And hospices? And
hospices. So I think since Dame Cicely set up that first the St Christopher's in 1967, there are now over 200 hospices in the UK. And I think when I was looking at Hospice UK, give them a little plug, they say they are treating now, we're treating over 300,000 people a year in hospices. So hospices do focus then on patients who have a terminal illness. You normally won't go to be involved with hospice care if you have a chance of cure. But that doesn't mean someone is imminently dying because they're under the hospice umbrella. So again, I've over the years had patients that are deemed palliative and terminally ill for years. I think especially as medical treatments have progressed, people can live a lot longer with their cancer and other non-malignant illnesses as well, which I think often get forgotten. So your heart failures, your COPD, you know, respiratory problems that can have and dementia, really slow declines that medication keeps people going, but they still need all this support symptomatically, psychologically, socially. So yeah, so the hospices are there for patients with this life-limiting illnesses, or sort of terminal. You'll often have various different branches, so inpatient units, community staff that go and see patients in their own homes, day hospices where patients will literally come in, spend a few hours in the hospice, normally have a bit of an activity, sort of art therapies, various, you know, we often have complementary therapists and things involved there. I mean, St Christopher's, for example, actually does rehab. So a lot of they've got a small gym in there and help patients keep their fitness as much as possible. So it's all about making someone's life as good as possible, knowing that it's going to end. And that's sort of what hospices are set up for most of the time.
And it's a growing field as well. I think in what you said to me was by 2040 it's going to be like half as much again or something.
Yeah, I think they're talking about us. The prediction is that by 2040 there's going to be an extra 130,000 people a year needing the support of palliative care. And then I think quite a big thing, if you start looking at government and sort of issues that are being raised in the palliative care field, is that hospices are actually only, although they're free, you know, like the NHS, completely free at the point of access, they are only 1/3 funded by the NHS and central government, and the other 2/3 of the funding comes from charitable donations. And I think some of the figures I read were something like, out of the 1.6, I can't remember what it would be, billion it costs to run the hospices, 1 billion is through charities.
Right. Okay. I mean, I have to say, I thought it was all charitable. I was almost surprised to find there's government money in there. I didn't know that.
Yeah, no, there is.
Is that because there are some NHS hospices though?
No, there are, but I think because so many patients will get transferred from hospitals out to the hospices, there is it was acknowledged, I don't know when all this started and when, you know, when things possibly did go from fully charity to NHS funded, but they obviously do take some of the burden off of the NHS hospitals, so there is a small amount of their funding.
So is it an easy job then?
Get a breeze. No. I love it, and I think that makes it a lot easier. But no, I think the emotional toll of it often is very, very, you know, is really difficult. And you know, and even the bits that you feel like should be bread and butter, so symptom control, we kind of, you often have a drug to turn to, but people aren't machines. And they don't always respond to the medication and things in the way you're expecting, and it doesn't work. And but it's the supporting someone when it doesn't work, and you know, and kind of getting them on board for trying the next thing, and discussing obviously with the huge, you know, number of professionals I've got around me all the time as to what we do next. So I think very fortunately, because of what we do, it's recognised that it is a really difficult job, but we're all kind of in it together, and generally a very, very supportive unit towards each other as well as towards patients.
And is that the main source of support, as in peer support or colleague support? Or is there supervision at all? I mean, what?
There is sometimes. It can be a bit hit and miss. I mean, I think, again, the whole of the NHS need clinical supervision, but finding the supervisors that have the time to support that many people, you know, it can be, and that it's often, from my experiences anyway, the supervision I've been given has been by people like the clinical psychologists in the hospital. And again, they're trying to do that supervision while also holding a caseload and everything else. So it is there, it does happen, but actually we often reflect between us as a group of staff that we also supervise ourselves. It's a lot of peer support and a lot of these very open conversations, particularly at the end of meetings and things when we all get together and sit in a room. Yeah.
I would imagine also different people, different staff are going to find different situations difficult for personal reasons.
Absolutely, always.
Yeah.
Yeah, and it was quite nice. There are, you know, various teams I've worked with over the years where you would know each other's strengths and weaknesses, and you could very much know who you should send to certain patients and who you shouldn't. As a general rule, everyone thought if a patient was going to talk for a long time, I was the one to go to them, because I was very good at sitting and listening. And I was always a big fan of the "is there anything else" question, which would inevitably open up a whole stream of things. So yeah, but that's kind of, yeah, just how we did it.
Yeah. So what is hard about it then? Is it, I mean, obviously the patient, if they're suffering and the treatment's not working in the way you thought, as you might say, what else, Gemma?
What else? Well, I mean, it depends in which. So I think there were different challenges in different environments. As you said, I've worked in inpatient units in hospices. I've worked in the hospital, and I've worked in the community, seeing patients in their own homes. Through all of those had different challenges. I mean, I'll put my hands up. The hospital at times was very challenging, especially as I worked as a hospital palliative care nurse during COVID. So that was particularly challenging. And you know, just the sort of the speed with which everyone was dying and supporting. Again, it's often I find patients, you know, they do need an awful lot of support, but it's the people that are going to be living afterwards that really, it's the way their life is changing so drastically, and obviously often can't imagine how it's going to be without this person in their life, and supporting them through watching their loved one suffering. It's sort of common for me to actually have a patient even acknowledge that their loved one is suffering more than they are, that they often kind of go, but I might be in pain, but I know this is going to stop for me, but she's going to be on her own. And how, you know, this and that loved one is then going, you know, I can't bear seeing this person in this much pain, or whatever it is, because, you know, distress, just the fact they're deteriorating, you know, they're watching it happen. And I can't relate to dying myself, but I can completely relate to losing a loved one, and sitting with someone while they're going through that grief is difficult. You know, you sit and cry with them, and come home at the end of the day and try and carry on with 2 young kids as if that's completely normal.
Mm. Now, if it's okay, Gem, I'd like to think about the links between this and your other world. I mean, tell me if it's the right time to do that, because you decided to do some coaching. You're still working in the NHS.
Yeah.
Part-time, full-time? I don't know what you do.
It part-time.
Part-time, and you're doing your coach training.
Doing some coaching training, yes.
What links do you see?
Particularly with coaching, and palliative care, particularly sitting and listening is a big, you know, professionally, the links. But just seeing people going through a struggle. And I think that's it. It's this, they're recognizing there's something going on that's sort of too big for them on their own to process, and that they're reaching out to somebody to help them manage that journey and work their way through the journey.
Yeah. And all the ending stuff, of course.
All the ending stuff.
Yeah. But and I mean, I just before we invite others to join in, I just want to say Gemma and I spent a bit of time talking about some of the change models and how palliative care might relate to them, including Bridger's transitions model, which is got a lot of endings and transitions in it. Obviously, that's part of its name, and also the very famous Kubler-Ross. And I think between us, we renamed Kubler-Ross, which I quite liked. When you said, no, well, it doesn't quite work like that, you renamed it. So I think you should own that and name it again here.
The Kubler-Ross, instead of the model, we've said it is the Kubler-Ross muddle. The fact, and it is recognized when you're reading through it, that actually the 5 stages of death and dying, so you've got denial, anger, bargaining, depression, and acceptance, that these 5 stages do happen all at different times and could be 1 minute to the next. But the model, when you look at it, is fairly linear. And I think for someone that's not then reading, if you just see the model, you kind of expect that someone is just going to jump from one to the other in this perfect form. But yeah, really not. And actually, I almost, when I was thinking about it, I was like, actually, it makes me think more of the old spirograph that kids use, this pattern that's constantly jumping, and then your pencil goes off and you've got a stripe straight across. It's just, yeah, a muddle.
Mm. Let's give people a chance to join in and relate what you're talking about to their own field. And I don't want to over chair this or over MC it. I just like people. I think, Sibylla, have you got your hand up?
Yeah.
Can you hear me? I just say,
Oh.
We can hear you, but can I just say for everybody else, we can't always see the hands because I don't necessarily have everybody on the screen. So if you want to just speak up. But Sibylla, go for it.
Hi, thank you so much, Gemma. It was really wonderful. And I'm sorry I joined a little bit later. I had problems with my sound, which gave a bit of a panic of what I have to relinquish straight away in this beautiful seminar. I can't hear. No, thank you so much. I am a patient advocate for mainly for children working in hospitals, and I did my doctorate at Ashridge, writing about organizational change in the family while going, sitting in intensive care for 400 days myself. And I wanted to say that in the neonatal world and in the pediatric world, I have come to really admire the work of the palliative care units, in particular a lady called Alex Mancini-Smith, who's published, and I can put the reference on the chat, she published a volume on palliative care from the nurse's perspective, because she felt there were a lot of textbooks from the medical perspective, but not really the voice and the stories of the many nurses who have so much experience. But what I always thought was the palliative care units were amazing at innovation. So while the pediatric and neonatal units were much concerned about protocol and that kind of thing, there was much more of a team approach of, oh, they want to go swimming with their child. How can we do that? And, oh, they want to go to Paris. Yeah. How can we do that? So it is sort of the start is not, oh, we can't do that because it doesn't fit in the protocol. Is how could we make that possible? Yeah. And that was, I thought that was absolutely astounding, how they found solutions to some things that were really tricky and created some very triumphant moments for these families that were then subsequently really feeding from these memories. So yeah, I just sort of want to say, I have huge admiration, and I think in terms of generally bringing in the voice of the patient, I think palliative care is really the trailblazer.
Yeah, I think you're right. It's absolutely everything is patient-led, and the number of times, like you're saying, that you as a healthcare professional might walk into a situation thinking, well, I'm going to be seeing this person and I will be dealing with a symptom of pain or whatever. And actually you say to someone, what's the most important thing to you? And they say, I just want to take him swimming. And it can completely throw you. But you do then just go, well, that's fine, get it. We'll make that work. You know, the patients that want to go on a last holiday, that want to get married, all these things that we spend our time muddling through and trying to find a solution to make that priority happen for them is huge. Yeah, so thank you. Is there
James, can I just ask you to mull? You don't have to answer this immediately, but at some point, I just wondered, is there a connection between the stuff you're doing and leading through storms and this that you can see, or any of your other worlds? And Alex, I'm also thinking I mean, if you're an improvisation musician, your pieces don't actually have an ending written down when you're playing in a jazz band, but stuff ends. How do you manage endings in jazz? You know, and neither of you have to answer at the moment, but I'm just thinking about connections here.
I'm happy to be a filler while they're thinking, if that would work. Gemma, I was thinking about the huge gratitude that those of us who are alive, those of us who are not palliative nurses, feel for people like yourself. I'm wondering how healing or restorative thank you really is. I mean, this is a huge question, but there's something about the recognition, and forgive me being unkind about recognition and reward schemes, because there is a need and there is a place, and I was a district nurse a long time ago, and thank you is huge.
Yeah.
But there's also kind of the enforced fun bit of, you know, great people that you've never met in your life coming and saying thank you, and you're like, well, that's great, but I'm sorry, I have no idea who you are.
Yeah.
So all that. So I mean, it's true, isn't it?
It's like the new lanyard that you get as a thank you.
The new lanyard, Lord, yes. So there's something about how healing and restorative is thank you for you.
Yeah, I think personally huge, but like you say, but when it's meaningful. So like you say, the organisational pat on the back of a new lanyard and aren't you great, and oh look, it's hot today, so here's a nice lolly. Thank you for all you do. I'm like, you don't have a clue who I am or what I do. But the thank you that I get from the relative, that it's why I do it, you know, it's a big part of why I do what I do, because I do know that I have that impact, but hearing it helps.
Yeah. And so there's something there about and about it is okay to feel good about having done a good job, even though it's what in the living world, we're particularly talking about the care of the dying, not just palliative care, and I take your point about the difference. But I think it's very interesting to think about that is okay to feel good about something, and to feel that genuine, authentic recognition. And just a little addendum, and then I will shut up. Does faith help in, I'm thinking big handfuls here, help in ways that you've seen make a difference? So people of faith, whatever the faith is, it doesn't matter. Does that make a difference, a significant difference to those of non-faith across, whether it's, I mean, particularly acute, of course, in the care of the dying, but in palliative care and symptom management and the psychological? Is that a component that you have explored or might explore in terms of what you've seen?
I suppose I haven't explored it, but I also, it's not something I would say jumps out, you know, talking that it has a huge impact. So I think if someone has a faith and that is very important to them, then their faith and spirituality will play a huge part in what's going on for them. However, I wouldn't say that the people without a faith, for example, suffer more. You know, I think it's just everyone comes at it from a different perspective. I have had patients that have a real wobble, and that's one of the bits I struggle with. So either someone that's never been religious that suddenly starts questioning what next and their spirituality.
Right.
And on the other flip side, someone who's very spiritual and starts questioning that faith because they've become so ill and has the, well, but I've done everything I should have done. And now
very
I'm
interesting
not.
because the engagement at work and enjoyment at work surveys and the work from Gartner and various other people have said those with faith feel more joy at work, particularly Hindus and Buddhists, apparently. Christians are down there somewhere, I'm not sure where. But you know, that's sort of really interesting that is an environment of a professional pleasure. And therefore, if you're on the receiving end of an ending, there's something about, does it make a difference? And of course, and I will now be quiet because there are 3 hounds and I am going to shut up. But then, of course, what's that like for the carer as well? So I'm gonna leave it there, but I think there's a longer conversation to be had.
Absolutely, it sounds like it. No, it's brilliant. Thank you.
I mean, I've got like 100 questions coming from this, which I'm not going to ask because in order it was Ed and then Emma and then Sarah. Ed.
This is a bit of a pivot or a slightly different direction, which is I was really just the if it's all about swimming with your grandchild in the sea or whatever it is, and you pull out the stops and you're like, let's make it happen. And that ability to find a way of doing something that feels meaningful, which is really interesting in that context. And I'm thinking in terms of risk appetite. So when you've got, whether teams, organizations, whatever, who are sort of carrying on in some form, they don't know what it is, but there is a sort of, I mean, particularly in healthcare, but other environments, of where there are serious human consequences, you know, harm, death, but also organizational, of if we push the boat out, and literally push the boat out, you know, do something differently, what might go wrong? Or, you know, the things, the brakes on, you know, kind of pushing the boundaries of what is possible. And I'm kind of curious in terms of the willingness to, well, to embrace risk, to innovate, to dig deep, to those situations where you're in an interesting space where you've got one person in the party where there is an end, and then you've got other people where there is a continuation. And I'm kind of curious in terms of how can we generate that willingness, that readiness to go, actually, do you know what, this feels like it's not 100% sure what's going to happen, but it feels important at this point, so let's take a punt. And whether you've got any perspectives on that.
I don't know, really. That's an interesting one. I mean, I think within my environment, we take a punt on most things, because they're important. But yeah, there will always be that safety. And there are times that we go, as a team, we'll be planning something, partly going, I'm not sure this is going to come off. Partly, yeah, it's a real tricky one. But I think my approach to all of these situations is honesty and open communication about it. You know, if someone said to me, I want to, I mean, for example, I won't go into the details, but I have had someone that wanted to fly to return home, and because of various surgeries they had couldn't. But it was the open conversations we had about what they wanted, why they wanted it, and he didn't fly home, he ended up driving home across Europe, because we said, well, no, but so the important part for you is getting there, we've just got to change how you're doing it. Yeah, but and then from organizational point of view.
Yeah, I can see so many organizational parallels with this, you know, because I've just seen Joe's comment in the chat about organisational change, and it's also made me thinking, God, most organisational change I've seen examples really badly done and really well done, but hardly ever would I describe it as, patient-centered, in terms of, what do people really, really want in this change? What should we be trying to do? And who is there in the role of really holding the ending of something? And the answer is usually nobody at all. I mean, when I've been working in organisations as an employee, I've even had situations where people say, well, that's finished, just get on with it. Stop looking backwards, look forwards. You go, well, it's not quite the whole story, is it? But folks, I sadly need to go because I'm on another thing. So I'm going to leave you in Gemma and Philippa's capable hands. And Emma, I think, is next. So
Thank you. Thanks ever so much. You might have covered this already, Gemma. Thank you. I mean, what I really heard was the the kind of what's on the other side of, whether it's for the individual or their families, that's the most challenging. And I was really interested in your insights about what's your experience of kind of getting to the root of an individual's fears and at what stage, because I'm kind of drawing parallels, I think, between people not taking steps because of, fight, flight, fear. Obviously it's different for you, but I just wonder what your insights on that are.
I mean, I think as far as discovering the fears, it's the sitting and listening to them. The number of times that that I get to it by just saying, okay, but what is it? Because I think at least in my environment, it's a question that everyone is scared to ask. Someone will be anxious, someone will, whatever, but everyone will just go, oh, or I suppose one of the key examples I've got, actually, it's slightly different perspective, but is the patient that I'll have a referral for because everyone's going, oh, they're in denial. They're not, they're not accepting their diagnosis. They're dying, but they're in denial about it. And I go and talk to them, and I'll just be going, but how are you about it all? What's going on? And actually, they turn around and say, well, no, I know I'm dying. I know this is going on. I just don't want to dwell on it, and I want to live, and I want to. But it's that taking the time to sit with someone to let them open up about it. And again, I remember sitting with a patient for an uncomfortably long period of time in silence, when he finally just turned around and just went, I'm scared of dying. But so many other professionals across the fields just don't have the time. But and I say it was uncomfortably long, it was probably only 2 or 3 minutes, but just sitting there with it just allowed him to go, there it is, it's on the table, I said it. And then we can explore it or not. And I think it's often just saying to someone, okay, I hear you, but and they might say they want to explore it further. They might also just say, that's enough for now, but I've said it now. And we can all just go, okay, how do we support him? We leave the room and go, how do we support him with this?
And
I might prioritize his visits.
Thank you. Thank you very much.
Thanks,
And
Emma.
I think, Gemma, some of the things, I've certainly seen organisationally is a combination of survivor's guilt. So in an organisational sense, those people who are not being made redundant or whose jobs are not changing significantly due to whatever is going on, they feel a guilt for doing it, so don't want to ask any questions. And there's also, I sometimes think, a little bit, I've seen an avoidance of, oh, I don't know how to deal with that, perhaps partially because of survivor's guilt, so I'm not going to ask that person who is being made redundant or their job is being changed radically in some way, or their team is being cut in half or sent to all different corners of the organization, that there's an embarrassment, and I don't want to ask, kind of, I suspect because people are afraid of what they might get back, that adds to their their own survivor's guilt. That's what I've seen in organisations. So there tends to be a bit of avoidance.
Yeah.
But actually, I think that point you're making about it only takes a very small question to have a disproportionate impact on the person concerned, both the person affected, to whom it's happening, so the equivalent of the patient in your world, and the equivalent of the family in your world. So the person whose team is being changed, and those who are not affected in that way organisationally.
Yeah, absolutely. I think it's the old, the visual for me is the bereaved person walking down the street and the friend crossing to the other side to avoid a conversation and a hello and a hug.
Yes.
Actually, for both people, it would probably be a really meaningful exchange, but it can be so difficult that people often turn away. And yeah.
And I'm often struck by the bit about saying I don't know what to say, whether it be in an organisational context or personally, can be really helpful. Sarah, you've been waiting very, very patiently, so thank you.
No worries. Super interesting, and thank you so much, Gemma. Lots and lots of thoughts about the analogy with organisations. Just three things, sort of questions for myself, really, not particularly Gemma for you, but I will be interested to know what you think. One is about, I think you just touched on it, about the extent to which in organisations we name endings. So just as at the end of life, you're talking about, conversations about, some people want to have conversations about the end of life and some people don't. I wonder in organisations the extent to which we are brave and confident enough to name that this is an ending. So that's one question. The second question is the importance of rituals at the end of life. I was really thinking about when you had the conversation with Caroline about thank you, because whilst there's something about you receiving thanks, or us receiving thanks, those who support others through change, there's also something about providing an opportunity for those dying. I'm thinking about my dad, who died 3 years ago, providing an opportunity for those people who are dying, and maybe organisations that are changing, teams that are ending, people who are leaving, to be able to say thank you. So, how do we enable rituals of endings within organisations? That's the second thing. And then the third thing, which was really prompted by something you said at the beginning about what used to happen, where people it wasn't a hospice movement, people weren't supported. I was wondering about, so why should organisations invest in supporting people through endings? Change happens all the time. What is there, and maybe the mindset of a lot of organisations is change happens all the time, so we'll just leave everybody to get on with the endings, but actually kind of like, I was wondering what is the case, if you like, for organisations, teams, groups, projects investing time in endings, because they don't do that.
No.
And I'm wondering, okay, so how might we make a really compelling case for the resources to support the coaching support, the ritual support, whatever other support for organisations to focus on endings as well. So those were some thoughts and questions that I had.
I could just add, so the last point there was one that actually I've thought about quite a lot through the sort of transition between two, and not that it's an answer to any sort of question, but something that always springs to mind is that part of the reason I do what I do and support people to die hopefully well, and for their families to see that person dying well, is because one of the biggest traumas I feel I come across will be someone that's experienced a bad death dying, because their automatic viewpoint is that they're going to suffer, that all these things that happen to their loved one is going to be what happens to them, and their inability to process that. So I do wonder sometimes if from an organisational perspective, if helping someone go through that ending and that transition means that the next time it happens, it's smooth again, and you can kind of bring everyone along on board because their previous experience of that change and that ending was so good that you're not then fighting it all the time. But that was, so far, that's been one of my thoughts on how it might help.
I certainly think we've seen exactly that in organisations. I don't know whether others who work a lot in different organisations have seen it as well. Joe, you've written another lovely comment. Would you just like to? Are you okay to unmute and just speak to both your comments? It'd be really helpful.
Sure. Yeah, I was just staying gently in the flow of the conversation and thinking about like I'm always interested, how can we bring this back to our lived experience, whether that's lived experience of relatives passing away, or lived experience of personal endings at work, or people that we care about or are close to in our workplaces, and the ways in which those endings play out. It's just so, it's almost like there's a sense of almost like some kind of fractal quality, I think. And that's what made me think about all organizational endings are personal as well, because we are involved in them. We are impacted by them, and they need to be done well. Like I'm thinking about the place I just finished working at, where they'd recently gotten rid of a whole service area related to community health, aged care, and walking through that part of the department, it's just empty desks piled on top of each other, and it felt so much like my dad's home, and he passed away at the beginning of the year. And when people die and they leave their kind of the relics, their possessions behind, there was such a strong kind of sense of those two, and kind of grief just sitting in the air around the people who were sitting by those desks. And yet, in contrast, something like somebody leaving under difficult circumstances, and it's not an organizational ending per se, but the impact of that can linger in the teams and their project spaces, or the relationships that they have across an organization. And so if we're thinking about how to support endings, we kind of need to work on both scales. We need to think about both scales.
Yeah, absolutely. Yeah, thanks for sharing that, Joe. Because again, it's something that through coaching and things I've thought about, where it's like actually the number of times if go really tragic end of all this, of a colleague dying suddenly, and there can often be that everyone says, oh, if you need the manager or whatever, I've got an open door, come and talk to me if you need to, but by the way, you've just got to pile in and just cover the work, and we'll just it's acknowledged but pushed through as well. It's and I think it's that supporting everyone through. We spend the majority of our waking life at work. These people we're sat in an office with for me often they become as close to me as a lot of my family, because I'm actually with them more than I am with my husband and kids. And yeah, to have some of them, as you say, made redundant, whatever it might be, it has a huge impact. And I think there needs to be some recognition of that.
I'm just going to invite James in just a second, but Polly put a question in the chat about what does Gemma see as the components of a good ending? And I'm just linking that to one of the questions you had, Sarah, around about being confident to name an ending organisationally. And Gemma, I don't know if you see the components of part. Oh, James, you've just put your hand down. Does that mean that was your question?
No, I was just trusting you to be able to remember that I had my hand up.
I'm not sure you should trust that, but
test.
thank you. Okay, so Gemma, just this thing about what are the components of a good ending, and then coming back, linking it perhaps to Sarah's comment about being confident to name the ending.
Yeah, so I think that the naming an ending is vital. And in my field, that could be naming it a year in advance, that we're starting to say, actually, this person is, they've got an illness that means their prognosis is likely to be short, or something sudden happens. But naming that ending gives the patient the time to hopefully process it, if they physically have the time, but helps the family acknowledge it and therefore start to transition. And part of the work a lot of hospices and things do is also pre-bereavement work. So it's working with someone that has the knowledge that this change is about to happen. And I do see one of the big components of a good ending is acknowledging that it's going to happen, to allow people to talk about what will make it good for them. Because, and I think that's one of the biggest things about my job, is everyone's an individual, and what's important to them, like talking about the going swimming, will be different for everyone. But for someone to have a good ending, I think we need to know what's important for them, because it will be different.
And just you just talking about time there, it's striking me that organisationally, quite often these things, because they're working to a project plan, are rushed through without perhaps recognising, or yes, perhaps recognising for whatever reason that a little bit more time actually might deliver a better result overall, in terms of being able to, the whole process will be better, the survivors will deal better, the organisation will deal better. And I just wanted to share one story of a ritual, because I know, Sarah, that was one of your questions. I heard about in an organisation. I have seen rituals, but this was the one that I didn't witness it directly, but I heard about it, where the culture in an organisation was changing, and they used to describe the culture as being, because of the way the organisation had grown, that it was called the red book. Their sort of their organisational history was in the red book. And when the big change came along, the current managing director actually did a series of roadshows around the organisation where he talked about the Red Book, and basically talked very fondly about the Red Book, how it had served the organisation really well. I don't know all the contents of it, but how it had served the organisation really well. But now the organisation was moving to a new phase, to a different place, and that, essentially thanking, this symbol for having helped, but acknowledging that now they were moving beyond that. And apparently from the stories that I heard, that it was incredibly helpful and cathartic, and really did help with that transition. And it was a very specific ritual or symbol that was given. Now, James, just to prove that I haven't forgotten that you had your hand up.
I was never in doubt. There's so much here. Thank you, everybody, for what you've added so far. I thought I'd take the opportunity to respond to Chris's question of Alex and I. From a deep adaptation to the climate and ecological emergency point of view, there are so many parallels, and I could pick up billions of things. Just that last bit about naming the situation, it seems that for us to really deeply adapt to the societal collapse that we're in, we first of all need to acknowledge that. And that often is like, we just can't go near that. Mm. And so we're really interested in why can't we go near that? And some situations seem to be that we're clinging on to old ideas, just like we won't die, we're clinging on to ideas that we will resolve the climate and ecological emergency in a way which means everything can stay as it is. Or we may be clinging on to ideas that, well, I've built my career on all of this basically extractive capitalism, which has been incredibly beneficial for many, many of us. But now what you're saying to me is that this is part of the issue, and I don't want to reconcile myself to the fact that I may be part of the challenge, just like we all are, but that's too painful for me to acknowledge. I've got some responsibility for this, and as a result, you take me to be a bad person, which of course isn't the truth. For many of us, we can reconcile to that. I think it brings up questions about what's important, as you've been talking about, that swim or the driving, the getting home. Mm. We want to restore something in our lives which perhaps we've forgotten about or that has been overlooked. And we talk a lot about what do we need to restore to allow ourselves to reconcile ourselves, to allow us that space to build resilience as well. Actually, I think what you've talked about a lot is resilience in community, both in terms of how you peer support one another, in terms of the listening, I mean, you know, that deeply listening, that allowing time, it reminds me of a phrase we use a lot, which is used a lot in these circles now. You know, this is an emergency. We must slow down. So that counterintuitive thing is, well, they're going to die. We haven't got much time. Well, actually, if we can reflect together, not rush, we've got more chance of reconciling ourselves properly to the situation, I guess. And those reflections, we know, all of us know on this call, how important reflections are. And it struck me that that means that we're more likely to go together through what this is, the death, in this case, of an individual physical body. And so we can kind of build that, we can work on that together. And this is a bit of a muddle, right? Some of what I'm saying. So I'm going in the Kubler-Ross muddle style of things, just hoping that some of these things will prompt others. But that acknowledgement, that clinging onto old ideas, and it feels to me that what you do, Gemma, and having witnessed it a month ago with a friend of mine as well, so I can feel the rawness for me, actually, and the respect of what you're doing. It does open up to some humor and some, you know, like, oh my God, I spent a lot of my life trying to accumulate financial wealth. And I'm now really being challenged at the fact that I can't take any of it with me. I work so hard on all of this. So it gets us to question, again, ideas about identity.
Yeah.
And I think that, again, comes back to, perhaps I'll stop here. It comes back to that first bit here. If I'm not prepared to acknowledge my part in things and also go, what's really important, what is my identity, then it's really hard to then move on to the next bit, because I'm in that, I guess, that denial, that anger, pushing against phase. And I can't then build the resilience. I can't have that cathartic reconciliation and relinquishment that's really important, that allows us then to build the community around whatever this death is, so that we can do it together rather than trying to fight against it. That's what it prompted in me. I wonder what others would see from that or take from that.
Gemma, do you want to any responses to what James has been saying?
I mean, I just think it's some really, really interesting thoughts. Yeah, I don't think I've got a particular response. I don't know if anyone else has got any thoughts about what he's saying.
Can I add to that if you like? Thank you for that. I was thinking, for me, you know, many people don't engage with death for so many years, and as we get older, we inevitably have to. And for me, this conversation is really powerful, because it's about how we make sense of the world, and the ability to engage with death, whether it's our own mortality or people dying around us. It changes the way we make sense of ourselves and others. And it might hopefully create greater compassion for ourselves, for other people, and for ecosystems and the planet and so on, linking to James's comments. And for me, it's about enabling us to reflect on our purpose. So when we know time is limited, we might reflect on, you know, why we're here. But organizationally, again, to engage with mortality, I've seen it affect organizations reflect on their organizational purpose at the same time. And I suppose this ability to change the way you sense the world requires us all to engage directly with, you know, with death. Maybe we all need to have experiences of caring for the dying as well, which inevitably we do have as we get older with parents, family, and friends, and so on. And of course, if I reflect on myself, it never happened really for me in any significant way when I was younger, or when I saw death, it didn't really register in quite the same way. So I'm just rambling again, really. But for me, it links to the sense of purpose is the key thing. The way we make sense of the world, you know. And people often talk about the fact that, you know, an average life is, you know, 4,000 weeks. It sounds like kind of short, you know. So again, that might sound a little bit morbid to talk about that to some people, but actually, if I'm engaging in conversations we have this finite time, it invigorates people to live their best lives now, or again, from an organizational perspective, to make sure that their organization is the best organization with a deep sense of purpose. So those are my reflections, building upon what everyone has said, and I'm very grateful for all those thoughts. Thank you.
Gemma, how does that, do you see when people are dying, do they have this sort of sense of really utilizing time well towards the end? It might be a very short period of time, or did that, that question that Alex was also asking around purpose?
I mean, I think it fluctuates, but yes, there can be. And I remember as I say, when I was starting my nursing placement at St Christopher's as my final year, and Grandad had only died a few weeks before, I was really nervous about walking in through these hospice doors, about what it was going to bring up in me. But I actually walked in, and it was one of the most positive environments that I've ever been in. And I think so. I mean, St Christopher's in particular, but they've got a community cafe. So you walk through the front entrance, and there's a community cafe overlooking the garden that their day hospice use. And it's this sense that everyone there is trying to make the most of their life, and that shift, that sort of really the ethos of palliative care is all about the quality of life. It's making the most of that time you have, and that is so often the feeling you get. It's not the morbid depression. It's this uplifting, I've got a finite amount of time, and I need to embrace it. And yeah, so that's very much what I see quite often.
People always say that hospices are amongst the most cheerful places they've ever actually been, which I think always surprises people for some reason.
Yeah, absolutely. But I think so often everyone in there is just willing to engage in open conversations, and as I say, and just wanting, I think so often, because people don't want to sit, do the conversation avoidance and things, that being somewhere where everyone will just listen to each other just means everyone relaxes. People want to have a laugh. They don't want someone to kind of come and look at them with the pity and bring them down. What they want is that, yeah, I'm still a person, I'm still me, I still have my same likes, dislikes, I'm still cantankerous, I'm still but that's me, and I want to be me. And yeah, and so that's very much the feeling I always get going into hospices and patient homes.
Sibylla, you did exactly as Chris asked and put your hand up in the old-fashioned way. So if you just take yourself off mute, then if you take yourself off mute, bottom left-hand side.
Yeah, thank you. I just wanted to, I mean, I can't tell you how much I'm really enjoying this conversation and learning from it. So it's really wonderful. I had two thoughts listening to all of you in my mind. I was thinking about how, and also having dealt a lot with grief and death and families with grief, and also learning about the selectiveness with which you can talk to certain people about it or not. You kind of create your own network of change agents, people who can cope with talking about death and people who can't. So it's kind of quite interesting. So you wouldn't know who is ready for this and who isn't. And I was thinking to myself, how can I get from saying to you, Gemma, thank you for the work you do in this very highly intimate liminal space, to creating the next layer of the work we do, widening the circle of people who do the work, and the work then being part of a wider circle, either organizationally or socially, but also being the bridge to people who do the work. So not to have this kind of bubble, this very highly intimate bubble of people who do the work, but making this part of our everyday lives, and creating positive rituals, naming, all that's very very possible. And also the shock of realizing how few people can really deal with their own emotions. It's the big taboo is the emotions that you feel and the avoidance of it. And I also wanted to thank you, Gemma, for this sentence you said at the very beginning, which is, this work is about making someone's life as good as possible, knowing it is going to end. And I mean, this is this relates to every single situation in our lives, right? Making an organization's life as good as possible, knowing it's going to end, making a family's life as good as possible, knowing it's going to end. So I think if we think about quality of work and improvement and innovation and risk, I think it's helpful to put that lens on our work once in a while, and make our work better and more meaningful. So just some thoughts.
Gemma, I saw you nodding a lot to what Sibylla was saying. Is there anything you'd like to respond
well,
to?
I think it it's just gone completely blank. It was where I suppose one of the big things for me when I was sort of studying and when I first started working in palliative care was how much of a taboo there is around death. You know, and even when I was talking to Dad, setting this call up and things, and I think I just used the word dying, and you know, and he went, "Is that something you use all the time?" I was like, "Yes, it's just part of my vocabulary, you know, that I try not to use." And for me, it's like trying not to use the passing away, passing on, you know, it's that acknowledgement. It's, you know, that it's a death, and it's but that and he was sort of saying, reflecting and saying that in business that's just not, it's so not acknowledged. But yeah, so that's why at the beginning I was like, yep, that's so common. And just as a society, I think it used to be, you know, probably centuries ago, that people would die in the home and everyone would come and see a body and all this, and it became, in more recent history, something that happened behind closed doors and wasn't spoken of. And it's trying to open that back up to something that is acknowledged and something that is, yeah, recognised and discussed.
James, you've got your hand up.
Oh yeah. It was just that last bit, Sibylla and Gemma, then two things came up. One was this idea that the acknowledgement that we struggle with, which is someone said to me, which I really value, all that can be lost will be lost. And seeing the freedom in that rather than the tragedy in that. And it means I don't have to be something, I don't have to pretend to be something to you in a way. I can acknowledge that. And when you're talking about dying versus passing, it's like, well, that is the truth of it.
Mm.
And then you're talking about hospices being some of the jolliest places without over romanticizing them. But this sense of, I wondered if that's got something to do with that as well, in that we don't have to uphold an identity in the same way if we're acknowledging death. We don't, and if we're acknowledging the imperfections in our lives, we don't have to spend loads and loads of energy pretending to be something for everybody else. We can actually just go, you know what? And that energy is then released into spirited action or whatever it may be, fun, whatever, because I've only got a certain pot of emotional energy, I'm guessing. And I either have to use it to kind of keep you out and make sure you see James as a certain type of person, or I can go, bollocks to all of that. This is me with all my flaws, and this is all the things I've done or whatever. And then it's free to just be, you know, alongside other people. And that, I have a sense that that might have something to do with what you're talking about as well.
Yeah, I think it probably does. It's, yeah, as you say, people, they have a finite amount of energy and they want to use it, as you say, just, I am me, I'm with the people I love, and yeah, I use, and we talk often actually about energy reserves at end of life and using that energy you have for the things that are important. So not the front. But
I think that's a beautiful observation, and thank you, James, and then Gemma, for adding to it. We're nearly out of time, and I can see that we could carry on talking about this for quite a while. I just wanted to just say that Fiona, who's had to go, but she put a comment in the chat saying that she was observing about reflecting on the contrast between feeling like time is short in the run up to an ending, and then the new beginning feeling like time is dragging as it's a time for adjustment, and the new chapter doesn't all come together immediately, and it's a huge contrast in pace of life or work. And I certainly can see that in personal grief that I've had, when people have died, and then also in organisational life. And I think it comes back to, Gemma, when you talked about the Kubler-Ross grief curve, it not being a model but being a muddle, because it does it as linear, but actually that's not how the life works. I just wonder if you've got anything, sort of any final comments in response to what Fiona had put in the chat.
No, I mean, I do think it's something that happens all the time. Like you say, that it can feel like a long time for the new beginning to start, and that dragging the grief through. I think it's often the two just sort of run alongside each other for quite a while, and like the Kubler-Ross model, that the bits will pop up at all sorts of moments throughout that journey and throughout the transition.
Yeah, and I think one of the things is that for those who aren't familiar with the Bridges transition model, it's one of the few frameworks I've ever seen that actually acknowledges that one thing is ending and something may well be starting as something else is ending. It's not a hard stop and then something, it's a process rather than, and we'll send that out to people. So that actually brings us to the end. Thank you, Jo, for that comment about a dance for aloneness and togetherness. They're all beautiful comments. So thank you very much to everybody for joining in, for coming to the pop-up. Thank you very much to Gemma for taking the time to come and speak to us. We've really enjoyed it and really benefited from it. So thank you very much. And to those of you who are doing those emoji hand signals, thank you. Clapping, I think it is. So thank you very much, Gemma. Just to advertise our next pop-up, we're not doing anything in August, on the basis that hopefully all of us will be having a break at some point. But on the 19th of September, we have Mark Cole, who is coming to talk about taking time to think. Again, please just sign up. The advert will be on what we send out after today, and also it's on our website. So 19th of September at 8:30, and Rick is just pointing at me because he's just put it in the link. Thank you very much, Rick, for doing that. So thank you very much to everybody, and it's 10 o'clock, so goodbye, and we'll see you next time. Bye-bye.
Thank you.
Thank you.